I will be sharing with Dr. Nsiah-Asare. We have 4 very exciting presentations here, and it's all about prevention. So, what is new in prevention, and what's the update in prevention? So we have like 4 speakers, but just give me like 1 second. Let me talk about prevention, which I think is a critical component of what we do to address this epidemic. We were told by several speakers yesterday and this morning that the gains we are getting in the epidemic is getting smaller year on or year after year. We were also told from the UNA's 2019 report that our efforts to reach the 2020 targets for reduction in HIV infection, and then that effort is clearly off the track. More than half of new HIV infections in 2018 occurred among key populations. We understand that young people are also a problem. I'm sure we're going to hear about this. In terms of figures, I'm quoting UNAIDS again, 2010, 2.1 million new infections. 2018, 1.7. Out of this 1.7, 1.1 is in Africa. So that's a real big burden that we have. And we've been told time and time again that we have all the tools to address prevention at whatever level, particularly at community level. So that is why this session is a very important session for us. That we hear some of the very recent studies that were done on prevention and studies that were done particularly in Africa. So it's very, very key for us as African scientists, African advocates, African community intervention, civil society organizations and NGOs to really get to know some of the studies that have been extremely useful in terms of addressing HIV prevention in our various communities. So we have 4 speakers who will address prevention here at this house. I will introduce the first 2, and then my co-chair will introduce the other 2. The first presentation will be done by Dr. Gambo Aliyu. Dr. Gambo Aliyu will be talking about, Dr. Gambo Aliyu will be talking about the Nigerian National HIV/AIDS Indicator and Impact Survey, which is called NICE. I didn't want to misspell or mispronounce it, so I was being very careful. But Dr. Gambo Aliyu is the current Director General of the National AIDS Control Program in Nigeria. He was an assistant professor in epidemiology and public health at the University of Maryland School of Medicine, Baltimore. He was also the country director of the University of Maryland programs in Nigeria, and actually was the leader and the chief of party for this very important survey. I understand that it's been one of the largest, remains one of the largest surveys that has been done. So can I therefore give Dr. Gambo Aliyu the floor to present his story.
Thank you, Chair. My respected colleagues, good afternoon. Let me see the slides over here. So, a couple of things. When I saw this topic, what is new in HIV prevention focus NICE? The first thing that comes to my mind is...
we can't hear you. Can you speak to the microphone?
Sorry. Is it clear now?
Yeah.
Yeah. So my first reaction when I saw the topic, what is new in HIV prevention focus on NICE? The question that comes to my mind is, so what is new? Can I think and probably relate that to NICE? But what I did just the summary thing was I had slides prepared, but only this morning my computer crashed. And I woke up trying to edit the slides to present you, and the slides were nowhere to be found. So I hurriedly called a friend. I said, can you come to my school? She said, okay, let's see what we can do. So she took the last 2 hours to put this stuff together. I hope I will do justice to it. And for those of us who want to know more about NICE, there is a whole session in NICE coming on Friday in terms of the way NICE was implemented, lesson learned, as well as the results. But I will quickly rush through these slides and see what we can learn out of it. I think she has done a great job. When these tough questions come, I'll point to her and just let her answer. Yeah. So, NICE is a fair model survey that are currently ongoing globally. And as the chair said, is one of the largest HIV survey done. Indeed, in Nigeria, the largest HIV survey done. We visited about 100,000 households, interviewed over 225,000 people, respondents age 0-64, and collected biomedical and behavioral data from these individuals over 22 weeks, over a period of 22 weeks. So the survey was implemented in MEDS, and we were in every MGA in Nigeria and almost in every selected enumeration area. It was fun, actually. 5 months or 22 good weeks on the roads with over 500 vehicles. So in terms of overview of NICE, I hope this is clear. In terms of the findings, you can see up there that the national prevalence, which is about 1.4 based on NICE, the pattern indicated here is showing most of the states in the northern Nigeria, below the national average, or just hovering around the national prevalence. But when you come to the north central and you go down south, you see where the epidemic is concentrated, and perhaps probably where the actions are regions right now. So this is just to give you a breakdown by age and sex. And the interesting thing is that you see the burden is now concentrated on the older age group, perhaps probably because of the 15 years investment that has been on actually. And I think this is where NICE is telling us over the last 15 years of paper investment and global fund, we've actually done very well. And whatever we're doing, we should keep on doing them. These guys have survived and they still live. And perhaps probably that is why when we do service like this, we still count them and you see the burden gravitating up there. We've seen cases of geriatric HIV 50 years and above. But our worrying thing is the transgender sex that is occurring between those older age group and younger age group, who are one of our key focus population for intervention. This is just giving us an overview of prevalence of viral loss suppression, because what we look out for in IS include HIV prevalence states and national, or national and subnational. We look also at level of viral suppression, national and subnational, and also national incidence, in addition to other secondary things like hepatitis B and hepatitis C. So what we're seeing here is interesting. You can see in terms of viral loss suppression, the pattern is not as we have seen with the burden. You know, some states, especially in the north central, are doing fairly very well. And also in the northeast, some states are doing well. While in the northwest and some states in the south are actually trailing. So what is there in NICE that has helped us to shape our decisions in terms of how we program going forward, and in terms of how we target population groups for prevention? This is what happened immediately after NICE. We had a rapid analysis. What I mean rapid analysis, a quick analysis was done. This analysis was led by Prof. And I can see he included 2 slides from Prof. Quick analysis was done by Prof. to identify where the taps are running and how can we move quickly with our intervention and see how we stop this tap from running. And also places where the taps are not running fast but are running moderately and slowly, and see how we carefully organize our programs so that as we're taking care of states with fast running taps, those with moderate and low running taps are following up. So, and then innovative strategies. And I think here some of the points she's putting together is to just key into the theme of ICASA, where we are looking at innovation, communities, as well as political leadership. So these are the, based on this analysis, and this is basically spectrum data, it's not only NICE data alone. And what this analysis does was to identify areas of greater impact where the unmet need is huge and the saturation in terms of services are low. What you're seeing there is these red states that identify are states that we've targeted, to move in fast, because these are the states where the taps are running fast. These are the states with high burden and states where the viral loss suppression is low, as well as activities in terms of enrolling, identifying new cases and enrolling them on treatment is actually low. Those yellow states that you see below are states that are low impact zone, where the unmet need is low and the saturation is also low. But the interesting thing is that the states that are looking green are the states actually that are our champions in terms of 15 years investment of Prof. But these are the states that have done very well, in terms of their saturation level. They have low unmet need and they're highly saturated. Some of the states have achieved the 90-90 goal. So our task collectively, Government of Nigeria, PEFA and Global Fund, is to move all those states you're looking at, the red and the yellow, to the lower end there, to the green zone, where all of them achieve UNAIDS global target, 90-90-90. Okay, sorry. So after identifying these fast running taps, the next goal is to identify our targets, new treatment targets. We've seen those states and we've characterized them. In fact, 2 of them we have moved first, and these are the 2 surge states. And this is one of the innovative interventions. Move in quickly, saturate other states in terms of programs at facility level as well as at community level, focusing on key affected population and focusing on youth and other population groups that are believed to drive the epidemic, but they are at large. I should have mentioned earlier that, you know, out of the 2,654 HIV positive individuals that were identified during NICE, 1,334 of them actually don't know they have HIV. They don't know about their status, and these are there out in the population. Given as the first indicator of first 90 that are barely around 50%. So around 50% of people actually living with this disease are out in the population, and there may be individuals who don't want to come to the facility, they don't want to even discuss HIV, and they are very resistant to come into the facility. So how do you make them up? Take these services to the community level where you lead them, find them, and probably bring them to facilities, or if you cannot bring them to facilities, provide services for them there. So these are the met needs that we realize that, you know, categorizing these states, red, and you can see red, the first two red, we're looking at 216,000 between now and the end of next year. And the second red, which are about 5 states, we're looking at 57,000 bringing on treatment, you know. And the rest green, which are saturated, we're still looking up to getting about 56,000 among them. While those huge numbers that we see, huge states below, that are the yellow zone in previous slides, we're looking at somewhere about 14,000 individuals new to bring to care. So what are the population groups for impact? Looking at NICE data and looking at the search strategies now that have been unveiled and is up and running, and is running very successfully, you know, Rivers and Akwa Ibom states where the burden is high, and also the rate of identification of new infection is also coming up high, and we are seeing positive yield from key affected population in those states. So the key affected population are topmost our priority, and thus include the MSM, the female sex workers, and individuals who inject drugs. Government, at the government level, we have just renewed our guideline program for key population, which means this guideline is supposed to guide political leaders, implementers, and even the key population themselves in terms of what program should go to what and how programs among key population should be implemented. We implemented index testing, and I think we have a very high yield. Some people in here that are currently working on Akwa Ibom and Rivers State can testify to that. We're getting individuals, especially among the key populations, you know, their contacts that are HIV positive. The next in line is recency testing. I didn't mention it here, but it's coming up. You know, it's going to key into index testing to help us identify those with infection, and these are the greatest part, the tasks that are running individual-wise. One-stop shop. We have these integrated services where this group of individuals don't need to go to facility, government-owned facility or other facilities to treat malaria and other things. When they come for HIV treatment, we take care of other things also to just make them happy. We have also Prof that is now available and has now been implemented among the affected population. And we have harm reduction measures that we're introducing, you know, among individuals who inject drugs. And a new harm reduction technical working group is right now in place. The next group that is very important, the adolescents and young persons. And these are individuals that don't key into our program. They don't even believe that HIV is a problem any longer. I had an interaction with a couple of them. They were telling me, well, even if there's HIV, there's treatment around, so they don't think HIV is much of a problem. Our challenge now is how to reshape our programs to connect to them, to make sure that they are buying into our programs, and our programs are making impact, and at least these programs are acceptable. So we are looking at parents, we are looking at their guardians, we are looking at their teachers, and we are developing communication toolkits for parents to talk to this group of individuals, adolescents and young adults about their sexuality and the risks of HIV infection and other sexually transmitted infections actually. Family life and health education program has been there before, but now has been revitalized by the Ministry of Education, and is also aimed at that. There has been a campaign program that was recently implemented by UNICEF in Kaduna, Lagos, Benue, and the FCT, and this was pilot tested just to see how we can get comprehensive education and health uptake across to this group. And I think initial data that come up in terms of getting to validate after giving them this education and then coming back later to see the impact, I think it's reassuring. It's not out yet, but I think it's on its way. We have also revived a national HIV and AIDS prevention intervention among national youth service corps. Youth service corps are freshly graduated individuals that are mandated to serve the country 1 year after their first degree. So these individuals, are highly accessible because they come and they are trained in camps in states. So we develop peer education program that they educate among themselves. They take to educate their colleagues, about HIV, about risks of HIV infection, and because most of them go to schools to teach. Actually, they are deployed to schools, so among the schools that are deployed to teach, we also encourage them to develop this peer education group among secondary schools students. We also have Association of Young Persons Living with HIV/AIDS now that has come up, and these are individuals that come forward. They are actually civil society organizations that come forward to help with adolescents adherence to treatment, and also to see whether they can help in tracking defaulters, especially those that have been initiated on treatment in their community. And I think the outcome has been impressive. In terms of condom and lubricant programming, we are going total market approach, which means the social and commercial marketing of condom, has been encouraged by government of Nigeria. The commercial marketing as the condom that has been produced and individuals buy them at commercial rate. But the social is the one that is actually free, but we don't want to say it is free, so we attach some kind of stipend so that people will give some kind of importance to it. While the free distribution is what government distributes. And we are also introducing national forecasting and quantification of condoms and lubricants. These are already included in our procurement, supply, chain management processes, and we want to make sure that going forward, the data on these are captured. We also have national condom and lubricant communication and demand creation strategy already developed. So in terms of the third layer of the ICASA team, political leadership, the universal health coverage in Nigeria, has been up and running, and money has been set aside, and this money is directed from the source. And 10,000 primary health care centers have been recently renovated. They are equipped. They are provided human resources. Okay, I have 2 minutes. They are provided human resources and basic health care to provide basic health care for all, including HIV testing for pregnant women and general population. There is an annual pledge, a pledge for annual increment of 50,000 people living with HIV or treatment supported by government of Nigeria. Until last year, until today, government of Nigeria has supported 50,000 individuals on treatment out of almost 1 million that are on treatment supported by IFAN Global Fund. Going forward next year, government of Nigeria will incrementally add 50,000. Money is already set aside for 2020, 50,000 to be added on government budget to government treatment plan for next year. So there is also integration of reproductive, maternal, neonatal, child, adolescent health, nutrition, and nutrition into HIV services, which means somebody coming for HIV services get their services. Also, somebody going for these services get HIV services as well. All had quest to promote HIV prevention, promote HIV awareness, and promote uptake of HIV preventive measures. Government of Nigeria appreciate the contributions of PEFA, Global Fund, UN agencies, implementing partners, CSOs, communities that makes the difference. Thank you.
Thank you very much, Dr. Aliyu. I know we have many comments and questions, but we want to be efficient. So we want to take all the questions and comments at the end of all the presentations. So please write them down so that we can be smart with this session. So our second presentation is going to be done by Professor Quarraisha Karim. She is an Associate Scientific Director at Quarraisha. She's the Principal Investigator of Quarraisha Clinical Trials Unit. She's Professor in Clinical Epidemiology, Columbia University. She's also a UN Special Advisor for Adolescents and HIV, and an Honorary Professor in Public Health, University of KwaZulu-Natal. I've known Quarraisha for a long time, well over 1.5 decades. And she's going to talk to us today about the population effects of the antiretroviral therapy to reduce HIV transmission, popularly known as POMAN. It's a very important study that was done in Africa, so I'm sure Quarraisha will take us through it.
Thank you very much, Chairperson, for that very warm introduction. Unfortunately, the error that came up in the program that I'll be talking about, pop art, has not been corrected. I was asked to talk about prevention in young women. So I do have a bit of test and treat in my presentation, and I do want to thank the previous speaker for laying some of the foundations in terms of the epidemiology and the importance of understanding the evolving epidemic in order to prioritize our responses at a local level. So just as a quick overview, given that the chairperson has already provided the global context, I'm going to go right into the mismatch between the high burden of HIV in young women in Africa and HIV prevention technologies for women, or ways that women can initiate and prevent themselves from getting infected. I'm going to talk a little bit about the role of behavior and biology and how that increases risk in young women in Africa. A little bit of forward thinking in terms of future technologies we can look forward to, and some concluding remarks. So of the 4,500 new HIV infections that are occurring each day, about 1,000 are in adolescent girls and young women in sub-Saharan Africa. And I think throughout this conference you will hear repeatedly that prevention and primary prevention is a major challenge. So while we've made good progress on reducing mother-to-child transmission and working towards getting to the 90 targets for the 2020 targets, that we way off the 500,000 infections we should be having in 2020. And there are many reasons for this, and even as we look at the progress we've made in prevention, we're seeing some great successes in different parts of the world, but we're also seeing some alarming increases in some regions of the world, particularly Eastern Europe and Central Asia, and now from the more recent data, we see increasing rates of new infections in the Middle East and North Africa. But generally, when we look at prevention, one of the biggest challenges we have is the populations we're leaving behind. And these are the key populations that are discriminated against for some reason or the other. But in sub-Saharan Africa, it really is adolescent girls and young women that's driving the high rates of infection. And when we think about the success we've made in PMTCT, in the programs that we've introduced in the early 2000s, what we're seeing is the survival benefits of that, an increasing number of young people who have survived the exposure, have remained uninfected, now entering adolescence, and this is now getting combined with the horizontal transmission that has been a long-standing challenge. To summarize, young women 15 to 24 years have up to 6 times more HIV compared to their male peers, and this large difference is largely in Eastern and Southern Africa. And with programs that have been put into place through PEPFAR, government-level responses, we're starting to see reductions in that, but the reductions in incidence rates is not as high as we would like it to be. So we're getting towards the right direction, but still many challenges. And I'm going to share with you some data as we move along in the next few minutes. So given this burden of infection that we have in adolescent girls and young women, and we compare the tools that we have available for prevention, abstinence, behavior change, both male and female condoms, and medical male circumcision, we have to ask ourselves which of these are prevention tools for young women in Africa. And until recently, that remained a major gap, until a very long road of testing many products, topical products, oral products, etc. We finally, in 2015, had these guidelines from WHO that recommended PrEP as global standard for all at high risk at high risk of infection. So when we look at who has access to PrEP, this is the picture that we see, and you see there are a few countries that have made PrEP available, but access for adolescent girls and young women remains a challenge, and I'll return to that in a bit. But given the UNAIDS theme of communities making a difference, and also the need to look at how do we translate the available knowledge into practice, I wanted to focus the rest of my talk on a community that I've been working in for the past 20 years. It's a rural community of about 500,000 people, which is about 150 kilometers west of Durban. So this is on the east coast of South Africa. And it has what is being described as a hyper-endemic epidemic situation. And if we look at data from a population-based survey that was conducted that included just over 10,000 households, you see a picture not too different from what my colleague Gambo just presented, which is that very low rates of infection up to age 15, and then from 15 to 19 you start to see the red bar, which is infection in women, rising and continuing to rise new, and started a campaign called Isibaya Samadota, which means that men take responsibility. So just over a period of 2 years, what we've seen is by this campaign, which started off with information and then grew to taking mobile services and treating men, we did highlight that in this community, 8 times more women are infected than men. We started to see an increase in uptake of treatment in men. And specifically what we found by doing these repeat cross-sectional surveys, nested within which these cross-sectional surveys is we have cohorts, and we follow these cohorts and look at who becomes infected, if uninfected, and those who are infected, how many are on treatment, and how many are virally suppressed. What we saw was a 2.5-fold increase in viral suppression from 15.9% to 39.4% in men 24 to 29 years. What's significant is that the primary outcome was temporal changes in incidence by age and sex. And what we found was that HIV incidence declined 43% from 4.63 to 2.74 per 100 person years follow-up in 15 to 19-year-old women. So what this highlights is that when we have data, and we have data at a granular level, and we target our intervention. So preventing infection in young women just doesn't mean we need to find new technologies for women. That if we find the right men, we initiate them on treatment, they virally suppress, we can also have a substantial impact on reducing incidence rates in young women. And I just want to emphasize that. So sometimes when we talk 90-90-90, it is a target. Our 2030 goal is to get to 3-0, 0 new infections, 0 deaths, 0 stigma and discrimination. So 90-90-90 in itself does not necessarily translate to reduction in incidence rates. And from this study, what we learned is that many men who have been recently infected in that age group, about a third of them, if they were tested with viral load and are transmitting the virus. So we have to do strong prevention efforts in women, and we have to look at PrEP, and we have to look at treatment as prevention jointly. I'm going to move now from the behavior to biology, and we've again previously described the using data from the Quarraisha 004 trial, where we found that drug levels wasn't sufficient in terms of protection. And there was a threshold that was needed of 1,000 nanograms per ml to get about 75% protection. So we tried to understand the mechanisms by which tenofovir prodrug is taken in, and basically what we found was there was competition during the 2 phosphorylation steps, and by doing some cytokine panel assays, we were able to identify women with a particular cytokine profile, 5 out of 9 cytokines, where we found an increased risk of HIV infection. More recent analysis tells us that not only does general inflammation increase HIV risk about 2.5-fold, but it also reduces the potency of topical PrEP. And what we've been seeing is that one particular cytokine, IL-17, is central to an inflammatory cascade in the female genital tract. So you may wonder, why am I telling you all this biology? Because if you recall, our success in PMT-CT came from a very solid understanding where transmission was taking place and how. Why do we have triple therapy? Again, it comes from a solid understanding. These are gaps in women's risk and vulnerability that we're only just starting to fill, and the more we know this biology, the more smarter we can be in terms of how we respond to the epidemic, either in new science or in implementation. What ILC7 does is mobilizes T alpha cells, and what we have is an increase in CD4 cells at the mucosal surface, which is just what HIV needs to establish infection. In fact, this work by Philip Selhorst tells us that in the presence of genital inflammation, even low infectious strains of HIV are able to establish infection. So if you didn't have inflammation, these low infectivity viruses would not be able to establish infection. So telling you again the significance of it. This work from Nicole Platt, looking at proteomics and identifying the microbiome and what's dominating, shows us how vaginal dysbiosis, in other words, the absence of lactobacillus crispatus, increases the pH, reduces hydrogen peroxide production, and changes the profile of the organisms in the genital tract to one where you have more anaerobic pathogenic organisms. And what we've been able to see particularly is this organism, Prevotella bevia, just with its presence, you know that they are 19 times more likely to have inflammation and also 13 times more likely to have acquire HIV infection. And then very quickly as I wrap up, it's this brand new data from Nature Communications on HPV infection. And what we found at baseline was that 74% of the women had HPV infection, 50% with oncogenic strains, and again, independent of other confounders, we see an increase and a substantial increase with the number of HPV infections, whether it's clearance of HPV infection, whether it's persistence of HPV infection. We have high rates of acquisition, telling us that HPV vaccines may play a role in reducing HIV acquisition rates. And then, there's a whole range of products that are being evaluated. And I hope at this stage that you understand the importance of preventing HIV infection in adolescent girls and young women, not only to alter the trajectory in Africa, but globally. We have daily oral Struvada that is in our hands, but we have to address the issue of inflammation, and a high priority is looking at how do we find tools that are less user adherent. But I want to end by saying that these biomedical interventions are only the first step. The root cause of vulnerability of young women is gender power dynamics, and we also are learning that gender-based violence has, and particularly in young people, have different trajectories in young boys compared to young women. And just to emphasize, in young boys it leads to more aggressive behavior. And what we have to be looking at is how do we enable rapid access. Now, adolescence to adulthood is a very complex process in itself. And when you add all these other challenges to it, it just complicates things, not making it impossible. But I think we need to appreciate that as challenging as it is, we cannot afford to ignore this challenge in our response to the epidemic in Africa and globally. I thank you for your attention.
Thank you very much. The next speaker is Samuelson. Julia is a nurse epidemiologist at the Department of Key Populations and Innovation Prevention of HIV/AIDS at WHO headquarters. Julia will be speaking on voluntary medical-based circumcision in an evolving HIV prevention landscape in East and Southern Africa. Evidence of sustained impact and realizing the benefits of reaching adolescent boys and men. When I saw the topic, I thought voluntary medical circumcision among men is not in Ghana or in West Africa. Everybody is almost circumcised. But I saw that it's in East and South Africa. Really over to you.
So while we're waiting for the technology to kick in, good afternoon. I'm pleased to be here to present about voluntary medical male circumcision in an evolving HIV prevention landscape. And the focus is in East and Southern Africa. I'll provide new information on impact and realizing the benefits of reaching adolescent boys and men with VMNC. I do want to give thanks to many people who have contributed to the research behind this work, as well as sharing their poster information, and I will point to that during the talk, and also contributing to this PowerPoint presentation. As a reminder, for some of those who may not be aware, because I was surprised very recently, someone who works in HIV and had no idea about the effect of male circumcision on HIV prevention. In 2007, WHO and UNAIDS recommended that medical male circumcision be recognized as an additional important intervention for the prevention of heterosexually acquired HIV in men. And as we move towards the 2020 and 2030 goals, some key questions that we thought that should be asked about VMNC is VMMC making an impact? It's been out there over a decade now. And is it still needed, given this new portfolio of prevention interventions? And if so, who needs to be reached in order to accelerate the reductions in HIV infection? And how can men and adolescent boys benefit further from developing VMMC? So this slide focuses on current HIV prevention status in East and Southern Africa. As shown by the circle graph, this epidemic is 75% in the general population, so largely heterosexually transmitted HIV. The graph on the right shows annual numbers of new HIV infections over a 30-year period, and this focuses only in East and Southern Africa. But the message is the same, that to get from where we are with the green line down to the blue dot of 230 new infections in 2020 is unlikely to be met. So dramatic changes are needed. So let's look further at the interventions and the role of VMMC. In 2007, the main interventions for primary prevention of heterosexually acquired HIV were safer sex education, just mentioned also by Quarraisha, condom promotion, post-exposure prophylaxis, and then the addition of VMMC. And when VMMC is being offered, as shown in the green diamond shape, at a minimum, it should be offered along with those prevention interventions, plus HIV testing and linking to treatment, as well as STI management. Now, the prevention interventions have evolved since then, and they also include PrEP, as we've just heard, and antiretroviral treatment with its secondary prevention effect. PrEP focuses on populations where there's a very high incidence of HIV. And also, as we've just heard, there are long-acting PrEP options that are coming, but they're a few years away, and vaccines and cures, unfortunately, are still further away. So this year, the results of 4 trials assessing universal test and treat provided some further insights on prevention interventions that are needed. UTT was achieved with intense community-based approaches to reach populations in their homes. And the 90-90-90, so testing, treatment, and viral suppression, were achieved. However, HIV incidence decreased between 20 and 32%, which was less than had been hoped for. So UTT alone will not reduce HIV transmission sufficiently to meet the prevention goals. The trials were originally conceived of as combination prevention trials. However, less attention was given to the other prevention interventions that are noted here. And PrEP was not widely available at the time, but it is becoming more available now. So let's take a closer look now at the evidence on VMMC's impact to prevent HIV. An updated systematic review, which is currently in publication, identified 19 studies over the past 20 years in diverse settings with 130,000 person years. It included only studies with data on HIV incidence that compared HIV risk among circumcised men to uncircumcised men. The forest plot that you see on the left has a vertical black line, which represents no difference in HIV risk if a man is circumcised or not. And to the left of that line represents a reduced risk of HIV infection. The studies the 19 studies were organized by type. So the 3 well-known RCTs, 2 extended follow-up studies, 4 cohort studies of men in higher risk groups, community-based cohorts, 5 before MC scale-up, and 5 during the scale-up of both VMMC and ART. The diamonds show the pooled results for each of these types of studies. And as you see, all of the diamonds are to the left of the black line, indicating a lower risk. As seen by the green diamond, again, from the 3 landmark RCTs, there was a 59% reduction in risk of heterosexually acquired HIV among circumcised men. As shown by the pale orange diamond, among men in higher risk cohorts, there was a 66% reduction in HIV risk. And moving further down to the darker blue diamond near the bottom, the impact in the 5 communities where VMMC services had been implemented in parallel with increasing ART coverage, the risk of infection was 45% lower. So at the very bottom is the red diamond, and this represents all of the data from these studies pooled together, which showed a 55% lower risk among circumcised compared to uncircumcised men. In summary, the evidence on VMMC to prevent HIV infection is remarkably consistent over several decades. If you want a great teaching example for public health, this is it. So let's look a bit further, though, at the impact in communities where both VMMC and ART were scaled up in parallel. It is difficult to disentangle the effect of each of these. An analysis was done on HIV incidence from the Baha'i community cohort during the period 1999 to 2013, and this is being updated. What it showed at that time was that MC was scaled up to 39% and ART coverage among women to 26%. For each 10% increase in circumcision prevalence, there was an associated 13% lower HIV incidence among men, while for each 10% increase in ART coverage among women, there was a 5% lower HIV incidence among men. This graph shows the modeled effect of VMMCs on HIV infections averted. The orange bars, which link to the numbers on the left, show the annual numbers of VMMCs between 2008 and 2018 across the priority countries, with a cumulative total of 23 million VMMCs that have been performed through 2018, something that was originally thought perhaps not possible. So those 23 million VMMCs have averted infections already. As shown by the purple line and linked with the numbers on the right, the direct and ineffect of these 23 million VMMCs is estimated to have averted 250,000 HIV infections over the past 10 years. And these numbers will continue to grow as men pass through their lifetime of sexual risk, perhaps growing to as much as 1.5 million infections to be averted by 2030. So when we look further at impact, again, in this scenario of both of these different interventions and safer sexual education being scaled up at the same time, if you look at the two bottom lines, the dotted red and the dotted black lines, this is the number of infections annually. And with the red line, it is all the interventions, the fast track interventions together, and this is the maximum impact on HIV infections averted that can be expected. The black dotted line is if you remove VMMC from that picture. Now, an important point to raise about VMMC is its lifelong, although partial, but lifelong effect. And this effect will continue in real-world settings where the challenges of viral suppression are continuing because of optimal adherence, or which could be due to stockouts or drug resistance. So, in brief, the lowest HIV incidence will be achieved by the combination prevention interventions, including VMMC in East and Southern Africa. So, is it still worth the money? Again, in the context of all these interventions. In brief, the answer is yes. And at the point, and this chart shows the cumulative net cost of VMMC and savings due to the ART costs averted, with the red arrow in this case in Zambia pointing to about 2025, 2026, which is when they will start to see cost savings from the investments made into VMMC intervention. And briefly, the benefits to women. There is a poster on this on Friday. Basically, there's the indirect effect that's anticipated and perhaps a lower HIV risk directly, except in the context of recent VMMC and wound healing. As well, VMMC reduces the risk of a number of STIs that are indicated here, and in particular for high-risk HPV, the onward subsequent cervical cancer cases and associated mortality will be reduced, and some estimates have been developed on that, but have not been costed into the benefits of VMMC. So despite this tremendous achievements in VMMC and HIV prevention since 2007, there's still more to be done. We need to reach HIV-negative adult men, and we also need to be reaching adults, adolescents, particularly mature adolescents. We need to be reorienting and expanding services for sexual reproductive health and moving towards universal health coverage. There's another poster, or actually two posters, that are available on Friday looking at who is at risk of HIV using the FIA data. The main message here is that HIV incidence in men becomes substantial after the age of 30 and in most of the VMMC countries, but this age group still sees a lower coverage of VMMC. And amongst the higher risk groups, those that I mentioned earlier, the types of groups were STI clients, trucking employees, and serodiscordant couples, as well in the cohort study in the Lake Victoria fishing communities with a high background prevalence of HIV. The reduction in HIV risk was 54%. So enhancing the uptake among adult men has been a real challenge for VMMC, like other HIV and health interventions. There have been a number of interventions that are being looked at and that we have some evidence on from comparative studies, but also from interventions that use program data. Those are listed here in the bold blue colors, and all of them are addressing one or multiple barriers ranging from awareness to availability and quality. And it's really important that people who are working in this area share these case studies as they move forward, because we can't be waiting for publications to be coming out and for these conferences. Otherwise, we're going to slow down the potential impact that we want to try to get to. So there's another poster that, and I'll just mention this, please visit on some examples on reaching older and high-risk men at STI and ANC clinics, and also, as the poster shows on the left, using MC as an entry point to make wellness clinics for men, which is making them more attractive for men, and also, again, moving towards universal health coverage. And nearly done, the adolescent HIV and sexual reproductive health service needs are now and therefore the future. You've already heard mentioned the youth balls that is having an impact on achieving the HIV prevention goals. There are some examples, one on the right from Zimbabwe, who undertook a participatory learning approach to link services between SRH and VMMC, and really drew upon community and parents and young people. And in the middle is an international technical guidance on comprehensive sexuality education. It's really critical that adolescents get the information that they need early in order to influence them and help to prevent a number of behaviors that become established in adolescence. So some of the lessons that we've learned, and also in answer to the initial questions, to prevent HIV and maximize these benefits of contact with adolescent boys and men, we really need to continue to promote VMMC as an essential intervention in combination prevention. The evidence is clear, even in the context of all of these other interventions. We need to reach men, including those at higher risk, and we need to be reaching adolescents better. We need to reorient and provide person-centered services and service delivery. We need to be capitalizing more on VMMC delivery as an entry point to provide other information and services. And we need to empower individuals, communities, and health systems to be able to do this. Thank you very much.
Thank you very much, Julia. The next speaker is Maju Shantani Ghana. She holds MPH and is a Director, Partnerships and Capacity Strengthening at AVAC. AVAC is Global Advocacy for HIV Prevention. She is going to take us through a question: prevention advocacy priorities, now what? And this is an echo study that is coming to present to us.
Good afternoon, everyone.
Good afternoon.
Are we awake?
Yes.
Excellent.
Thank you very much. While it's getting set up, thank you very much for inviting me to speak. I'm really delighted to be on this panel with such excellent speakers, and they've actually made my work really easy for me because they have set up the global context well. But I will say that I was asked to come and speak literally as I was getting on a plane. And the reason I agreed to speak today is because when I looked at this session, a really important special session on HIV prevention, what's new, and I realized there was no civil society person invited to speak. And civil society is really important in moving forward prevention. So I'm delighted to be here to give that perspective. So in this presentation, I'm going to talk about what's new in prevention, but more importantly, I'm going to talk about what new things we can do to move it forward, and the priorities that we're proposing to the leaders in all places and spaces. So if you read the news, things look great. It looks like we have all the tools we need to end the epidemic, that we have lots of investment into the epidemic as well, and as the New York Times says, we have a glimpse of hope of ending AIDS. In prevention science as well, it's a really exciting time. We have lots of new tools, more than ever before. We have new products that are being researched. We have new devices. We have big trials and communities that who've never been involved in research before, engaged in this. But the truth is more sobering. And everyone before me has described this in detail. 1.7 million new infected people. That's not great news. New infections continue to outpace treatment. Prevention tools are not being provided at an adequate scale. Young women and girls continue to be disproportionately affected. And Quarraisha she gave us a really good picture of that. When you go home tonight to your hotels and your homes, 850 women, young women, would have been infected. When you get on your plane at the end of the week to go home, 6,000 young women between the ages 15 and 24 would have been infected. The news is not so good for them. Stigma and discrimination impede prevention for men who have sex with men, sex workers and transgender people, the very people who need these infections. And recently, the ECHO trial showed us that we have a huge unmet need for integrated sexual and reproductive health. All of this is not great news. Earlier this morning, in a satellite session, Dr. Ambassador Burks actually talked about, if you look at the HIV spending, just in DREAMS and BMMC projects, we've spent a lot of time and a lot of money treating young women and preventing HIV in men. But actually we have tools now. We need to do something to balance that. Maybe that will help us address some of these pictures. So we're missing the target. We're almost at the 2020 deadline that UNAIDS set for reducing new infections to fewer than 500,000, and Julia talked about this. And although important progress has been made, the crisis we called for bringing infections down is still there, and we're actually far from it, if you look at the graph below. And again, as Julia described, the hope was that community-based testing and treatment would help in a big way to get us there. However, the results from the 4 large test and treat trials demonstrated that community-wide testing followed by ART could reduce incidence by about 30%, and more important, was really good at the individual level. And as invaluable as that is, it's insufficient to keep up with the pace of new infections. But there were other things included in the 2020 targets for us to get to the 500,000 infections. The model said we need to do a few more things, and we've put some of them here, and you can see the huge gaps even in them. So for example, we wanted to have 3 million people on PrEP. Right now, we have 385,000 people on PrEP. Guess where most of them are? Not in Africa. We said that to actually get to this goal, we needed to increase funding by $6.5 billion every year. We have flat funding. Even in those 90-90-90 targets, some countries are doing exceptionally well, but in some countries, the picture is actually dismal. So we still have a lot to do to get us there. So here we come. So now what? What do we do now? Every year, AVAC releases an annual report where we look at the prevention field and we look at some priorities in the field. So the answer you're going to find in this report about what do we do now, how do we go beyond that target, is sustain the investment, do more of the difficult things that have been put off, measure those things, modify the approaches, and repeat. We don't need to reinvent the wheel, we just need to reorient the direction we're going. We call for bold leadership that is visible and activist, from the new head of UNAIDS, go Winnie, to the Houses of Parliament, to civil society, to take uncompromising stances, demand accountability, speak out for intersectional issues of race and gender, class and climate. This work needs to be funded and it needs to be fearless. Second, we call for the use of today's most recent evidence to guide new prevention targets that pave the way for the epidemic control that we're looking for. We need clear milestones in prevention research so that investments can be better targeted. The options we have today we have them because of lots of investment in the last few decades, but now we need actual targets, really clear targets that everyone can understand and influence. Third, we call for a multi-layered prevention approach that is centered around the person and not the virus. The ECHO trial, again, that I spoke about, showed us the dynamic needs for HIV and pregnancy prevention. It also showed us the complexity in translating results to policy, and it also shows us the renewed urgency we have for comprehensive integrated approaches. Multi-layered prevention incorporates multi-purpose technologies, those that can prevent HIV, pregnancy, and STIs at the same time, as well as multi-layered prevention, multi-layered strategies within programs to address structural barriers like policy reform, transforming community norms, and education. 2020 will be a pivotal year. Join us in calling leaders from community spaces to global capitals to make it also a turning point, to break those silos, to make sure those crises are transformational, and to make sure prevention is really center stage. So even as we call for this call to action, we do it in a format that is really looking at research to roll out. One is not more important than the other. Within our framework, we call for delivering today prevention programs that is well defined, demonstrating next generation engagement for next generation trials. And what I mean is the future has really complex trials, really huge trials where lots of things are going on at the same time. We can't do business as usual with engage people in those trials. And also developing new targets for the post-2020 world. So when we think about future prevention, what do we have to think about now? We have to think about where's the greatest unmet need for prevention, what products will people want and use, how will we deliver next generation prevention, how to best balance our portfolio, how to keep R&D part of ending the AIDS epidemic. And we do have some great prevention options in the future. Some really cool new things. We have vaginal films, douches, implants, all that will be delivering HIV. The hope is more options means more choices to keep yourself safe, more coverage, and therefore more impact. But I want to caution us here. Options are not the same as choices. And I actually want to read out something that Dr. Sharon Hillier from the Microbicides Trials Network said. She said, options are things and choices are our decisions. A condom is a prevention option. Using condoms is a decision, is a choice, not a one that many women often don't get to make. Options are fixed, choices aren't. So I think that as advocates and everyone else is really fighting to develop those new options, to remember there's a lot of work to transform options into actual choices for people. So here's what we have now. What's currently available is HIV treatment for people living with HIV. We have oral PrEP, pre-exposure prophylaxis. We have male and female condoms, VMMC, and syringe exchange programs. We even have a brand new PrEP product that was introduced, which was approved a couple of months ago, called FTAF. It's another tenofovir-based product, and it was approved by the US FDA for, and I'm going to read this out, for people who do not engage in receptive vaginal sex. That means it's for men who have sex with men and transgender people who have sex with other men, or in other words, it's not for vaginas. We also have the Depivirine vaginal ring, which is a silicone ring that you use monthly. Well, women use monthly, and it releases Depivirine, which is an ARV, and it can protect you from HIV, and it's right now in regulatory review. If this gets approved, that will be a next new tool in the toolkit, really exciting. In development, and you heard a lot of this from Dr. Larry Corey this morning, broadly neutralizing antibodies that could really transform the way we do prevention, vaccine studies, more research in next generation PrEP. And further on in the development cycle, we have implants, vaginal inserts, patches, enemas. So really a rich field. Now, I'm not going to read this out, and I don't expect you to, but it's to give you a sense of how much we have going on. And this up here shows you new devices, new products, new tools, all that are being researched. So you can see it's really a rich prevention science field. But what do we need to focus on? What can I tell you to focus on in the next few years in terms of all this new research? So over here is a timeline for a few years, and on here is just the large clinical trials that are going on or are going to happen. So let me just bring your attention to a few things to look out for in 2020. So in 2020, like I said a few minutes ago, we're going to hear from the European Medicines Agency on their opinion on the Depivirine ring. If they give a positive opinion, it will fast-track WHO pre-qualification, and it would also help fast-track regulatory opinion from African regulators. It's also going to the US FDA, Food and Drug Administration, and also to SAHPRA, which is the South African equivalent of that. So watch out next year for that opinion. Also, what's going to happen next year is I talked about the FTAF study, which is not for vaginas. Well, we hear that Gilead is about to launch a new trial next year, and it will include 1,500 women from South Africa, maybe some other African countries, to look at that. And so watch out for that as well, and we understand they are really hoping to consult women in developing that study. Another exciting thing to look out for next year is a monthly PrEP pill. A monthly PrEP pill that will be going into the field. The AMP study, and you heard a lot about the AMP study today from Dr. Corey, and we're going to find out about the usefulness of broadly neutralizing antibodies. But research is the easy part. Getting it to the field is harder. So 7 years since we got PrEP approved, this is the picture of where it is. And it's not a great picture. We need to do a lot more to get tools to people. We need to avoid historic delays with introduction. And that includes making sure we don't wait till we have efficacy to understand the actual needs of users, to make sure we don't do small demonstration projects that aren't really responding to the questions that policymakers have, and to make sure that we have multi-stakeholder work putting this together and not lots of people doing lots of small things. The truth is, when we think about access, often we think about people making choices of what to use, but they only get to use what is available in programs. And what's available in programs is only what the policymakers and the funders decide to fund. So even when we think about access, yes, there are those who use and have to make choices about that, but they can only choose what is delivered, and they can only then get what somebody else decides to pay for. So as advocates, when we look at this, there's lots of different spaces that we have to do advocacy and move the dial. So back to now what? So in this report, we include letters to leaders. We have a first letter to young HIV-focused advocates who are already doing this work. We don't think of them as the next generation, we think of them as generation now, and they're really going to lead to the future. Next is a letter to the new ED of UNAIDS, and as one of the visible global leaders on HIV whose strong activism can move us forward. And these are the things we ask for in the letter to her. But what are the specifics? So I just want to give you one specific that we asked for in this report. So I talked about the ECHO trial a bit, so let me just tell you in 1 second what that was. The ECHO trial was a 3-arm study in which women from Eswatini, Kenya, South Africa, and Zambia were randomly assigned to one of 3 contraceptive methods: the Jadel implant, the copper IUD, and injectable Depo-Provera. The trial found no substantial difference in HIV between women using any of these methods. However, it did find higher than expected rates of HIV across the arms. Now, women in the ECHO trial were not recruited because of having high HIV risk characteristics. Rather, they were picked from communities with high HIV rate, but who were looking for contraception. High HIV rates, much higher than we expected. So now what? So civil society groups are moving to make sure women have the information they need to act on it. But it also brings up the importance of both multi-purpose programs and multi-layered programs. And every woman matters is our mantra here, and I encourage you to read about our 3D approach for this. So finally, what is your prevention priority? Yesterday, we had a biomedical prevention forum where advocates from across Africa came together to talk about prevention priorities. And at the end, we asked them to say what their prevention priorities were. So they tweeted, they gave me tons of little pieces of paper, I got Post-its, and this is just a couple of them. One advocate said we need to reach the VMMC target of 80% coverage in priority countries by 2025. Not lip service, actual action to make it work. One young woman said we need to decentralize the production of medicines in the region because we have the most impact and we need to do it here. We had another young woman who talked about it's not enough to engage community in research, but also engage them in thinking about how to get that product out. So I guess I'm challenging you here to think about what your HIV prevention priority is after you leave here and to tweet it with hashtag #MyHIVPreventionPriority. You can tag us at HIVPX Research, but more importantly, tag the policymaker or the leader who needs to act to make your prevention priority a reality. Thank you very much.
Thank you very much. Mind you, he said, what is your prevention priority? So everybody should be thinking about his or her prevention priority before we leave this room. And he also went through now, what is it? Should be bold, and also activist leadership from HIV approach. And then we have to use evidence to guide us to come out of what we are supposed to do to have a prevention and a targets. and the multifaceted, the multi-layered prevention approaches, which are central around the person. So it's person-centered, not the virus-centered. So these are some of the few things that I learned. I think we have had 4 very exciting presentations this afternoon. In order not to waste too much time, I will that everybody who has any question, just one very precise, short question. And no, we shouldn't go around it and then try to give another presentation. My co-chair said we have only about 5 minutes to leave this place. So one question each, very short question. If you go up beyond 2 minutes, I'll stop.
So I can talk loud. Is that okay? So I want to thank you guys for a very high energy, very informative session. My question for the panel as we think about prevention, one key population I didn't hear about and I wanted you to think about potentially is people who are over the age of 50, so older individuals acquiring HIV. And we should definitely be doing all that we're doing for the younger individuals who are infected and treated, but prevention in the older age group, I wonder if what your thoughts are about that. Thank you.
Thank you very much. I have this question to speaker number 2. I missed your explanation of the role of interleukin-17 in inducing vaginal inflammation and modify the vaginal microbiome. We understand its mechanism in causing enterocyte pathology very perfect. I just miss what you're talking about there.
Thank you all for very interesting and stimulating presentations. I just have a question from a colleague from Nigeria, which was great to see Nigeria coming up and using domestic funding. It was going to increase by 50,000 patients per year on treatment. I was just wondering what is the, if I recall, you said you had 1 million patients on treatment, so it seems to me it's going to take you 20 years to take over the full funding for this. And also, what is the increase in the number of patients coming onto treatment per year? So maybe you could look at that. And just a little comment to the chairman, before Julie made her intervention about circumcision, was the remark that in your country, circumcision is done systematically at a young age. Just to point out to everyone that the generalized epidemics that we saw in southern and eastern Africa, they only occurred in the world where there was a low prevalence of circumcision. And so these circumcision interventions are interventions that will hopefully transform the countries in southern and eastern Africa into sufficiently high circumcising countries that those epidemics never emerge again.
Ok, bonjour à toutes et à tous. Je vais parler en français. Je suis Kamara Ben Zakaria, un père éducateur du réseau Grandi Ensemble. Alors, ma question va à l'endroit du docteur Aliyu Gambo. Lors de son intervention, il a dit comme ça que les adolescents et jeunes refusaient, n'est-ce pas, d'intégrer leur programme. Moi, en tant que père éducateur, vraiment, j'ai chaud au cœur d'entendre cela. Je me dis par exemple c'est parce que les stratégies mises en place ne sont pas adaptées, raison pour laquelle ces adolescents et jeunes refusent d'intégrer le programme. Alors je voudrais savoir, quelle stratégie vous avez mis en place que ces jeunes, n'est-ce pas, puissent intégrer vos programmes? Et c'est ma question. Merci.
Yeah.
Donc, je réponds encore à la question.
We want somebody to interpret what you said.
Not much. Not much. Just more.
He said that you talk about the integration of young adolescents in the program, that they refuse to integrate the program. So he would like to know which strategy you implement to help these young and adolescents to be integrated in this kind of program in your intervention. Which one?
It's not for him.
The Nigerian?
It's not for him.
Okay. The first presentation. Did you get what he said? You understand, Dr. Aliyu? It's okay?
Yeah. So should I go ahead? Okay, there are three questions directed at me. One, the first question that is talking about geriatric HIV. What are we doing in terms of prevention among geriatric people? It is true, we've seen cases of geriatric HIV. A typical example, I think a couple of months ago, I was going to a state in Nigeria, and just before I go, I asked for nice data segregated by age. What I saw was general, population level data in the state, prevalence 0.8%. When we look at by age groups, 50 and above is 2%, and this is across male and female. So when I arrived, I was thinking our data was probably not correct. And what I did was to ask the HIV/AIDS coordination manager in the state that, look, this is what I'm seeing. I don't know whether my data are telling me the correct thing. He looked at me and laughed. I said, well, we have been going out and we've been doing outreach and we've been seeing cases of geriatric HIV. In fact, the funny thing is, when you get some of these individuals and you talk to them about HIV prevention, some of them are at around the age of 70 and above. And answer they give you is that, gentleman, if I die at the age of 70, it's celebration. So that thing you're asking me to use condom, when I use it, I apply it, it collapses. So what do you want to use? So that's why I throw it away. I don't need it, and I'm not going to use it. Now the problem is what I told the guy then is, so now how do you go about preventing HIV among this group? He said, well, the only option is look at the younger age group. They go after young females. So why don't we look at this? That's what is going to be a clear test. Another thing is, why don't we encourage them to start the ARV treatment? He said, oh, they're doing fine now. When you introduce them to ARV, they accept and they get the role of treatment. Perhaps probably this is one of the things on our side that will be encouraged. Get them on the treatment so that the treatment serves as prevention. The second one is sustainability. What are we doing? How is Nigeria going to catch up with 15,000 years? And Nigeria right now is talking about a million. So that will take us about 20 years. Yes. I think we are not only relying on the money the government of Nigeria is providing. The encouragement is for government to put in funding, for others also to follow. One thing we are looking at is private sector mobilize resources. We are about to launch what we call HIV Trust Fund. And this HIV Trust Fund is supposed to be money contributed by private sector to drive HIV program in Nigeria. We're hoping they will take up to 5 to 10% of HIV spending. Right now, the private sector is at 0.5%. 80% of HIV spending in Nigeria is shouldered by PEPFAR, and balance is shouldered by the government of Nigeria and the global fund. So if you take PEPFAR and global fund out of the equation, everything is going to collapse. But you know, as responsible partner and government, Nigerian government has pacted also to take responsibility, you know, in this treatment, and then to come forward so that other partners meet Nigeria midway. So that's what we are trying to portray. We want to be responsive, and we want to make sure that PEPFAR and Global Fund are seeing this effort and recognizing this effort, and also the private sector is mobilized. Going forward, we're looking at getting the state to take more responsibility. By the time we mobilize resources from states, and we mobilize resources that are available from basic healthcare provision fund that is available, by the time we get HIV individuals taken care of by insurance companies, as directed by Mr. President, then certainly down the road, we'll be able to fill the gap. But this gap perhaps probably will take over 10 years before we get it. The last question, for me, yes, is the one that is talking about what program do we have for you. As I said, we've just launched an association of young persons living with HIV, that is a civil society organization. These individuals have membership across the country, and they are mainly focusing on youth and adolescents and young persons that are enrolled on treatment or that are yet to know about their status. They are promoting HGS, they are promoting uptake of treatment, they are also promoting adherence. Not only that, they are also helping in tracking. And I have also mentioned the tools we're developing for parents, for school teachers, the engagement of our National Youth Service Corps in the peer review, and as well as taking this peer review to the schools they teach. All those are effort towards bringing those services to youth and getting youth to buy into our programs, including the awareness programs launched by UNICEF recently. Thank you.
Just quickly on the question of older people, and I'm speaking largely from Southern Africa, where before ARVs became available, life expectancy fell to about 44 to 49 years. Now that we see people with treatment surviving to over 50 and treatment also reducing onward transmission, we are starting to see more people over 50. And I think you're absolutely right that we need to start paying attention to it. I know in the communities I work with, for example, I highlighted in the one community, there are more people infected after the age of 30 than uninfected. But then as more people go on treatment, life expectancy is going up to about 60, 70 years, and we need to start paying attention to those age groups. The second question was about IL-17. Let me give you a short answer. IL-17 is a pro-inflammatory cytokine produced by T helper cells. Is the cascade that results from the activation of the IL-17 that results in higher density of CD4 cells at the genital tract. And in the female genital tract, that is the point of exposure, and that's what HIV needs. So in the non-genital inflammation genital tract, then you have pure CD4 cells. Where you have IL-17 activated, you have more CD4 cells, and so the cells that HIV needs to establish infection because of the high density is why you have a higher rate of acquisition. And I think those were my two things.
So regarding the question on the older individuals, in the context of the MMC, in looking at the acceptability for male circumcision in those who were older. One of the reasons was that the men said basically, it's not relevant for me. I'm not at much risk, and whether that's true or not is one one didn't explore. But so risk perception is, of course, an issue across ages, and with an increasing population who may be at risk at older ages, there may be a need for rethinking how to present risk perception to those who are older than 50 or 60 years of age. And just briefly to build on the comments on the integration for adolescents, very similarly to what you've been doing in Nigeria is the example, for example, from Zimbabwe, where they really went to the community and they really engaged with young people, and they really had the young people who were co-leading and co-producing the kind of services that they wanted to have, and that required the systems to work differently. So you need the youth sector, and even within health, you need reproductive health and HIV to come together. And I think that that was what was making things work at the local level, but the question is, how do you scale that up to the national level?
Great. After this very exciting 4 presentations, you will all agree with me that we have many things new in HIV prevention, and even the old tools that we have. We were excited to hear about new, innovative ways of approaching them, and some of the very exciting things that we can be expecting in the future. So again, this is a really exciting session, and you will, on behalf of my co-chair and all of you, we really want to thank all the presenters, and I think that anyone who wants to really engage them, we can engage them after the session. I'm sure they will oblige you. I will thank you once more for all your patience. I think that brings us to the end of our can you give them a round of applause?
Good.